Dear all, I, Dr. Pauman, am presenting a case of 56 years right-handed female who presented with a progressive blurring of vision in both eyes for last 3 months. The cranial nerve examination revealed a vision of 6 by 60 with bitemporal hemianopia and primary optic atrophy in both eyes. Otherwise, neurological examination was within normal limits. MRI brain was suggestive of a well-defined iso-intense lesion measuring approximately 2 into 2 cm seen in suprasellar region. After contrast administration, homogeneous post-contrast enhancement was seen. The lesion had a broad base to the sphenoid in the midline and abutted and elevated chiasma. No vascular encasement was seen. The MRI features favored the impression of meningioma. We plan to excise the lesion by endonasal endoscopic route with a preoperative diagnosis of tuberculum Sellae meningioma without any vascular encasement. At our center, the nasal and the initial part of the sphenoidal surgery is performed by ENT colleagues. We take over from cranial base drilling onwards. The nasal stage of surgery was uneventful. Halfway through the cranial base drilling, blood started oozing from the corner of dura and bone junction laterally. Dark red venous kind of bleed. Now, retrospectively thinking, it was from cavernous sinus. We thought we were still some distance away from the cavernous area at that time. We tried using Surgicel and warm saline irrigation. However, the trickle of ooze continued, for which we tried diathermy. The bleeding became brisk, if not torrential, and bright red colored within no time. Considering the location of brisk arterial blood, we suspected potential ICA injury by now. At this point, the endoscope was getting soiled with little vision. With the help of suction and some quick maneuvers, we could place Surgicel and gel foam at bleed side and pack the cavity. By the time we could plug the last gauze, blood was pouring out from the nose and oral cavity, and there was little to confirm. Moments later, the blood pouring out of the nasal cavity stopped. Our hypothesis is we could save the patient, probably because we did not go looking for the source of bleed and futile exercise of controlling it by endonasal route. At that time, we did not realize then that we could have used a muscle patch as a hemostatic agent. One of the lessons we learned is to harvest a significant chunk of muscle while harvesting fascia and fat from the thigh for all the endoscopic cases. We checked the pupils. They were 2 mm in both eyes and reactive to light. The whole exercise lasted a few minutes, and within this time frame, patient suffered cerebellar and occipital infarcts as seen on post-operative CT scan. The patient was taken for a CT angio. CT angio suggested a bone defect in the cavernous sinus area on the left side with active contrast extravasation. The next step would be DSA. DSA was suggestive of pseudoaneurysm in the cavernous segment of ICA. There was no cross flow on balloon occlusion test. At this point, we had two options, either flow diverter to take care of aneurysm only, or craniotomy with bypass and trapping the aneurysm and excision of the tumor. Nature of illness and management options were discussed with family. As the idiom goes, never forget why you started in the first place. The flow diverter option wasn't our first choice. Interventional techniques are superior because these pseudoaneurysms are challenging to clip, rather impossible to clip often. Intervention, however, may involve flow diverters, which are costly and not always affordable. Less expensive option is bypass followed by trapping of the segment. Our patient did not have a good cross-flow circulation. Though flow diverter would have helped us tiding over the crisis, the long-term requirement of dual antiplatelets would have made surgery difficult in the immediate future. The patient might have lost vision. The family chose surgery. Their view was that they would risk surgery than going blind. The patient was referred to Manipal Hospital, Udupi, as per the family wishes. The patient underwent left pterional craniotomy with drilling of clinoid, deroofing of optic canal, identification of the ICA rent. The rent had healed with a fibrotic scar. It was reinforced after coagulation with 2 layers of muscle and a fibrin glue. The patient is almost 3 months post-operative period and doing well. Lessons learned. Harvest muscle chunk at the time of harvesting fat and fascia. Constant focus on landmarks to maintain orientation of anatomy. Use diathermy sparingly. At the first suspicion of bleed, pack the cavity and get help. Ask the rest of the team to prepare for bleeding and hypotension. If bleeding was not stopped after packing and waiting, probably it won't. Do not go chasing the source of bleed nor waste precious time controlling it. One can always revisit the cavity later once one knows where we stand. Pack the cavity with muscle and other hemostatic agents and use thrombin products if required. However, using products like FlowSeal directly on the bleeding vessel may lead to embolism. Investigate the patient with CT angio and DSA if required with cross-flow studies. Endovascular treatment may tide over the crisis, but the future of vision of eyes is an important thing to factor in. Patient and family wishes take first preference.